I'll be talking about the glenoid labrum in this. I have no disclosures. We'll go through the anatomy and MR imaging of the normal glenoid labrum, talk about the normal labral variants, and then focus our attention on labral tears based on the location. So anterior inferior, posterior inferior, and superior labral tears. The glenohumeral joint has the greatest range of motion, so it's vulnerable to injury and instability. The joint stabilization relies on the labrum, the glenohumeral ligaments, rotator cuff, and the negative interarticular pressure. Actually, could you stop the looping? I think it's just looping. The negative interarticular pressure, which is the vacuum between the labrum and the humeral articular surface, also plays a role. The labrum is a fibrocartilaginous ring. It has collagen fibers in a circumferential orientation along the periphery of the glenoid rim. It deepens the glenoid fossa, increasing the contact between the humeral head and the glenoid cavity to stabilize the joint. It also protects cartilage from compression and shear damage. The labrum serves as attachment site for the long head biceps tendon, the superior glenohumeral ligament, middle glenohumeral ligament, the inferior glenohumeral ligament anterior band, and posterior band. The clock face has been described to describe the glenoid labrum. 12 o'clock has been superior, 3 o'clock as anterior, 6 o'clock as inferior, and 9 o'clock as posterior. In our practice, we find it's best to describe the labral pathology according to quadrants. So superior, anterosuperior, anteroinferior, inferior, posterior inferior, and posterior superior quadrants. Our shoulder protocol includes using a dedicated shoulder coil. We image the planes tailored to the glenohumeral joint. The pulse sequences are a combination of T1, proton density, T2 fat suppressed images, and if there is concern for calcification, metal, or gas, we would add an axial gradient echo sequence. Now, MR arthrography has several advantages over MRI, mainly related to the joint distension. It allows us to see distinguish the capsule from the labrum, allows us to see contrast tracking into the labrum in unstable tears, and between the labrum and the glenoid in labral detachment. We can do the therapeutic or diagnostic block at the same time. And MR arthrography is very useful for patients with chronic symptoms or subtle pathologic abnormality on clinical exam. We inject about 0.1 to 0.15 milliliter of gadolinium mixed with 20 milliliter of fluid, and a total of 10 to 12 milliliter of fluid is injected. We image with a combination of T1 with and without fat suppression, and then a T2 with fat suppression. An A-bear sequence may be added to your MR arthrography protocol. This is imaged when the shoulder is held in abduction external rotation. The elbow is flexed with a hand behind the head. As you can see here on this picture, patient supine. There's the coil. This allows us to see the anteroinferior labrum really well and undersurface rotator cuff tears. So here's an image of the A-bear. We image the A-bear sequence along the long axis of the humerus, and here's the A-bear image that we get. Notice the taut anteroinferior joint capsule in this case, and then the posterior superior structures become redundant on this sequence. So let's go through what a normal labrum should look like. On cross-sectional imaging, the most common shape is a triangle. So here we have an axial PD fat-suppressed image showing a normal triangle appearance of the anterior and posterior labrum. Remember also the normal labrum can look rounded. So here we have an axial MR arthrogram image showing a rounded morphology of the anterior labrum. The signal intensity of the labrum should be uniform, low signal with all MR sequences. In older patients, you can have inhomogeneous signal leading to degeneration. So here we have a coronal MR image showing the superior labrum with homogeneous dark signal intensity. The cartilage between the labrum and the glenoid is intermediate signal. So here you can see this normal cartilage undercutting underneath that labrum, and this should not be misinterpreted as a labral tear. We evaluate the superior labrum on the coronal oblique plane. So we have on the left a T2 fat suppressed image. On the right is a coronal MR arthrogram image showing the nice superior labrum that's normal, dark in signal intensity throughout, and triangular in shape. If we scroll through the coronal images from anterior to posterior, you can see go back. Here's the long head biceps tendon. As we follow the long head biceps tendon, you see it going into the anchor. And then the superior labrum is here. And then notice the normal cartilage undercutting beneath that superior labrum. Okay. The anterior and posterior labrum are evaluated on the axial plane. Here's the axial proton density fat suppressed image. You can see normal anterior and posterior labrum. Again, homogeneously dark. Notice the smooth capsule labral junction. When we evaluate the anterior labrum, we also look for the MGHL. When you follow the MGHL, the fibers should merge with the subscapularis. On the sagittal plane, we can evaluate the entire glenoid labrum in its entirety. We can also see the glenohumeral ligaments. Here you see the superior, middle, and inferior glenohumeral ligaments. Now, the normal variants occur most commonly in the superior and anterosuperior quadrants of the labrum. The most common variant that you'll encounter is a sublabral sulcus or a recess. It's been found to be in about 73% of cadaver studies. It represents a cleft between the superior labrum and the glenoid at or slightly posterior to the long head biceps origin. Remember, this normal variant should be thin, linear, and smooth. So here's an example. Axial image on the left, coronal image on the right, T1 fat suppressed MR arthrogram images. You can see a nice cleft between the glenoid and the superior labrum on the axial images here, and also on the coronal images here. Notice how the signal parallels the glenoid. So this is your sublabral sulcus. The sublabral foramen occurs in about 15% of cadaver studies. It represents focal detachment of the anterosuperior labrum from the glenoid. Again, it's high signal intensity that parallels the glenoid. So here's our sublabral foramen on MR. We have axial and coronal PDFS sequences. Here you can see a cleft, a separation of the anterosuperior labrum from the glenoid. Coronal images nicely showing this cleft that parallels the glenoid. The Buford complex occurs less commonly. It represents an absent anterosuperior labrum and a thick cord-like MGHL. So remember, the MGHL blends with the anterior capsule and subscapularis, so it helps you diagnose this normal variant. Here's our axial and sagittal MR arthrogram images. The axial image shows a nice thick MGHL. Notice the absent anterosuperior labrum. On the sagittal image, you see this nice thick MGHL. This is the Buford complex. Now, there's another variant that we should be aware of when we're looking especially for labral tears. This is the labral bicipital sulcus. It's a normal cleft between the undersurface of the long head biceps tendon and the superior labrum. So here we have a coronal T1 fat suppressed MR arthrogram image. Here's your long head biceps tendon as it's coming into the superior labrum. Notice right underneath it, you have the sulcus, and it may fill with contrast, so we should not misinterpret this as a labral tear. So let's talk about how do we distinguish labral tears from normal variants. In a labral tear, you see high signal within the labral substance. So as we have here, you see abnormal high signal intensity extending into the labral substance. A normal variant, this is our sublabral sulcus. Notice the high signal parallels the glenoid, nothing in the labrum itself. On an MR arthrogram, you see contrast extending into the labral substance and some of these labral tears, as we see here. In a normal variant, you do not see any contrast extending into the labral substance. So here's our sublabral sulcus. You see this fluid of contrast undercutting the labrum, but the labrum itself is normal. Labral tears would have irregular labral margins. Coronal images here showing irregular margins of a tear. And here again, our sublabral sulcus. Here's the cleft. Notice the smooth labral margins in this normal variant. Axial images also show you the irregular labral margins of a tear. And this is our sublabral foramen. Here's the nice focal separation. And then notice the labrum, normal, smooth labral margins. In a labral tear, you see high signal undercutting in the antero-inferior and postero-inferior quadrants. So as you see here, there's a separation of the antero-inferior labrum from the glenoid in the antero-inferior quadrant. This is your tear. Remember, your normal variants occur most commonly in the superior and antero-superior location. So here's your sublabral foramen. This is in the antero-superior quadrant. A labral tear, you may see an adjacent perilabral cyst. When you see a cyst, look really hard because there's likely a labral tear. A normal variant, you should not see any perilabral cyst, as in this case of the sublabral foramen. Okay, so let's talk about labral tears separated into different location. Antero-inferior labral tears, commonly associated with anterior instability. Postero-inferior tears are associated with posterior instability. And our superior tears are associated with our slap lesions and micro instability. Antero-inferior labral lesions are a result of antero-inferior dislocation or subluxation. And then we see our Bankart lesions in the variants. We also see a Hill-Sachs fracture, which is compression fracture of the posterolateral humeral head. And as Jeff said, is diagnosed within the first 3 superior axial images. So here you can see a nice Hill-Sachs fracture with the marrow edema. The classic Bankart lesion is a result of an anteriorly dislocated humeral head impacting on the antero-inferior labrum. So we see a detached antero-inferior labral ligamentous complex, and the periosteum is torn. So it can be purely labral, or it can avulse a piece of bone, and that could be an osseous Bankart. So here's an example, patient with history of recent anterior dislocation. You have your axial PD fat-suppressed image on the left and a sagittal T2 fat-suppressed image on the right. Here you can see that the antero-inferior labrum is detached from the glenoid. And I really like looking at the sagittal images for these cases because you actually see the detached labrum really well. So the sagittal images really help you on these cases. Another patient, history of anterior dislocation. Now look at the antero-inferior labrum. In this case, it's medially displaced, right? And then on the sagittal image, look how nicely you can see the tear actually extends up into the antero-superior quadrant. This is an extended labral tear. So on the sagittal images, we can see that the tear is more than the classic Bankart. It goes all the way up to the antero-superior quadrant. An osseous Bankart can be seen too. Here's the nice fracture seen on the coronal images, the sagittal T2 fat-suppressed image, and also the CT reformatted 3D image shows a displaced osseous fragment. Now we get into the different variants, Perthes and ALPSA. These are just Bankart variants. So the important thing to remember is treatment depends on the clinical instability and symptoms. So it's more important for us just to recognize the labral tear and the presence of the periosteal stripping rather than trying to name the different lesions. And we'll go through each lesion, but we can just consider these as Bankart variants. The Perthes lesion occurs when you have an antero-inferior labrum detached from the glenoid, but it's not displaced. There's minimal medial stripping of the intact scapular periosteum. So here in the illustration, you can see the antero-inferior labrum is detached from the glenoid, and there's minimal stripping of that periosteum that remains intact. On our axial PD fat suppressed image, you can see the anteroinferior labrum is detached from the glenoid. The periosteum is intact, but there's mild stripping of that periosteum. This would be a perthes. Okay. Notice the MGA gel anteriorly. So remember, when you look at the anterior labral pathology, always identify your MGA gel. Okay. An ALPSA lesion stands for anterior labral ligamentous periosteal sleeve avulsion. I think of this as kind of perthes getting worse. So now you're seeing anteroinferior labrum that's detached from the glenoid, and it's medially displaced. Remember the perthes, the labrum is not displaced. So here it's medially displaced. Look at the stripping of the intact periosteum. You get wider stripping in an ALPSA. So on MR images, here you can see the anteroinferior labrum is detached, and then the periosteum is stripped, allowing actually contrast to fill into that gap. So this is your ALPSA lesion. Now the ALPSA lesion often is a result of chronic injury and multiple dislocations. It has worse prognosis than the Bankart lesion and a higher arthroscopic failure rate. Here's the patient with multiple anterior dislocations. You can see the anteroinferior labrum is medially displaced. The periosteum is intact, but it's stripped. And if you notice that there's actually a lot of scar tissue around here. It's all this dark signal intensity, also on the T1 fat suppressed image. This is a chronic ALPSA lesion. So for us, we describe it. If you think there's a tear detachment, describe there's a tear detachment of the anteroinferior labrum. Is the periosteum intact or not? Rather than actually naming these lesions. The next thing, remember to evaluate cartilage in the labral tears. When we see these labral tears, look at the cartilage right adjacent to it. So here's your Bankart lesion, and there's kind of like fissuring of that cartilage right adjacent to it. So this patient will get a labral repair as well as a chondral debridement. So always look at that cartilage adjacent to that labral tear. This has been described as a GLAD lesion, a glenoid labral articular disruption. You don't have to use these names, but it's just a reminder for us to look at the cartilage. So initially, this was described in patients with superficial anteroinferior labral tears without any clinical instability. But we found that these cartilage abnormalities occur with patients with instability. So we just look at the cartilage adjacent to the labral tear, report if you see any cartilage defects. So here we have an anteroinferior labral tear. Actually, it's kind of detached from the glenoid here. And then look immediately at the cartilage adjacent to it, and you can see the chondral defect. So this would be a GLAD lesion. Posterior-inferior labral lesions commonly result of posterior dislocation and posterior instability. These two radiographs show you like light bulb appearance and then some posterior subluxation here. The reverse Bankart lesion is the detachment of the posterior-inferior labrum from the glenoid with tearing of that periosteum. So here's the diminutive posterior-inferior labral tear. And notice how the sagittal images are really helpful. You can see detachment of that labrum from the glenoid. Same patient, you get the reverse Hill-Sachs fracture of the anteromedial humeral head. Another case, posterior dislocation, tear of the posterior-inferior labrum, and then sagittal images nicely show you displacement of that labrum. A PULPSA lesion is similar to an ALPSA, but occurs posteriorly. So here you see a detached posterior-inferior labrum with stripping of the intact posterior periosteum. Okay. Let's move on to our superior labral lesions, which are the SLAP lesions, commonly associated with microinstability, result of minor acute trauma or chronic repetitive microtrauma. You can see this with swimmers or overhead throwing athletes. It's actually a difficult diagnosis because patients commonly present with nonspecific shoulder pain. In these cases, we find that MR arthrography is very useful. Okay. So SLAP lesions refer to tear of the superior labrum that extends anterior and posterior to the biceps anchor. It can propagate into the adjacent structures, long head biceps tendon origin, superior and middle inferior glenohumeral ligaments. Original classification by Snyder had type 1 to 4. Subsequently, as anything in radiology, now we have 10 types. But for us, really best to be descriptive. Just report the labral tear and which structure the tear extends into. Don't worry about typing it, because I bet you even the orthopedic surgeons don't remember the different types. Okay, so let's go through some of our SLAP lesion cases. First case here, MR arthrogram image, coronal image. Already you can see abnormal signal into the labral substance. And actually, this is the biceps anchor. So you see abnormal signal going into the biceps anchor there. Originally, this is described as a type 2. Don't worry again about the type. What we'll report is this is a SLAP lesion with some stripping of that biceps anchor. Another case, notice how these are mostly MR arthrogram images, because we find that arthrogram is really useful to diagnose a SLAP lesion. Okay. So here we have 2 coronal images. Notice that there's a tiny little fragment of labrum that's displaced, almost similar to your bucket handle or meniscal tear with a fragment that's displaced. Here's your biceps anchor, looks intact, right? Dark signal, no high signal going through. We'll report this out as a SLAP lesion with a bucket handle tear of the superior labrum and an intact biceps anchor. It's another case, coronal images again, MR arthrogram. Now you can see abnormal signal in the superior labrum. The right image shows the contrast going into the biceps anchor. Same patient, sagittal image and axial image. Here we can see on the axial images, look at how wide that signal is, separating the superior labrum from the glenoid. The sagittal image, here's the abnormal signal going into the biceps tendon. So this is reported out as a SLAP lesion extending into the biceps tendon. Okay, another case, coronal T1 fat suppressed image on the left, abnormal high signal in the superior labrum, and then the axial T1 image on the right showing the tear actually involves the antero-inferior labrum as well. So this is a SLAP lesion extending into the antero-inferior labrum, which is the same thing as an extended Bankart tear. So just describe the tear and exactly which quadrant it's in. Okay, another nice case here, coronal and axial MR arthrogram images. You can see separation of the superior labrum from the glenoid, a small little cyst that's filling with contrast. On the axial images, showing the same thing. Now we go down a little bit further, axial and sagittal T1 fat suppressed images here. You see abnormal contrast going into the MGHL. So this was a SLAP lesion extending into the MGHL. Okay, this is a 21-year-old male with shoulder pain. MR arthrogram was performed. We'll run through the coronal images from anterior to posterior. So here you go, you see this little fragment of labrum, kind of similar to the case I showed earlier. So there's that fragment of labrum. Okay, now the axial MR arthrogram images. Now notice how there's irregularity and high signal going into the SGHL, the superior glenohumeral ligament. There it is there. There's your labral tear. Subtle findings, but we thought this is probably a SLAP lesion that may be extending into the superior glenohumeral ligament. This is a case of, again, chronic shoulder pain. We have the coronal T2 fat suppressed image. Here we're seeing abnormal signal in the superior and inferior labrum. Notice the cysts, paralabral cysts adjacent there. The middle images are your axial proton density fat suppressed images, abnormal signal and morphology of the posterior labrum, as well as the anterior labrum. Notice all the paralabral cysts here. Sagittal image shows you nice extension of that abnormal signal into the biceps tendon. our impression was circumferential labral tear extending into the biceps tendon. So in summary, normal labral variants, such as a sublabral recess and foramen, usually occur in the superior and anterosuperior quadrants. Normal variants have high signal that parallels the glenoid rim with smooth labral margins. In comparison, labral tears have intrasubstance high signal and irregular labral margins. And when labral tears involve the antero-inferior or postero-inferior labrum, look for signs that may say that this was from an anterior or posterior dislocation. And then in our practice, it's best to describe the slap lesion and the structure the tear extends into. Thank you so much. And I think it's Jeff again coming up.